All right, so before we dive into this is going to be one of the tougher sections here. It's going to be the prenatal care complete review. So this is like one of the last things that you should review for your OBGYN rotation. It's very tricky, and I want you to focus on what I have bolded and in red in this section. So take a moment, pause the video, and we're going to come right back and jump into this section. All right, so let's dive right into this postnatal care or prenatal care complete review. So the normal prenatal visit schedule is every 4 weeks until 28 weeks gestation, and then every 2 weeks from 28 to 36 weeks of gestation, and then every single week until delivery after that. Do not memorize this list, but be familiar. So at the first prenatal care visit, regardless of the gestational age, basically you need to know that they get a ton of labs. So I'm not going to read all these to you, but here are all the labs that you get on your very first prenatal care visit. Very rarely are you going to get a question on this simply because it's such a large amalgamation of labs. But some important things to note is that a patient without prenatal screening with a baby that was born with an umbilical cord necrosis, you should think of congenital syphilis. And syphilis is one of those things that is very, very dangerous for the baby. So if they have umbilical cord necrosis, you should consider congenital syphilis. You'll also see things such as snuffles, which is a copious, purulent, serosanguinous rhinorrhea. They can have desquamating rashes of the palms and soles, and they can have periosteal thickening and metaphyseal erosion. If the umbilical artery has reversed end diastolic flow, you should consider placental insufficiency and impending fetal hypoxia with concomitant oligohydramnios, so these patients may need delivered right away. So reversed end diastolic flow is a bad sign, and it can show fetal hypoxia is impending. If it's a sickle cell patient, you need a baseline 24-hour urine collection for total protein, and this is due to the high risk of nephropathy with sickle cell disease, which puts the patient at an increased risk for preeclampsia. And for these patients with sickle cell, you'd begin aspirin at over 12 weeks gestation to decrease the preeclampsia risk. So those are kind of some like high-yield, overarching, big picture type things. So now let's break it down into the trimesters. So first trimester at 0 to 14 weeks is everything listed above, plus you want to start doing genetic testing, and so you can consider offering the following. So for invasive genetic testing, like chorionic villus sampling, this can be done at 10 to 13 weeks gestation, but it has a high risk for abortion, so some parents will opt out of it. Cell-free fetal DNA can start at over 10 weeks gestation, and so you test the DNA from the placental syncytiotrophoblaст cells found in the mother's blood. NBME will basically always want you to select cell-free fetal DNA as the next best step in a patient with age over 35 in order to evaluate for chromosomal abnormalities. If cell-free fetal DNA is positive at 10 to 13 weeks gestation, your next best step is chorionic villus sampling. If this occurs at 15 to 20 weeks gestation, your next best step is amniocentesis. So the number of weeks gestation is really important. You only are going to consider chorionic villus sampling at 10 to 13 weeks, and amniocentesis is going to be for 15 to 20 weeks. For first trimester screening, you can only obtain this at 9 to 13 weeks of gestation. You want to check serum markers for beta-HCG and PAPPA, and so also look for nuchal translucency. If the patient is high risk for diabetes, do an early 1-hour glucose challenge test. That's also another option. So now moving on to second trimester. This is at 14 to 28 weeks. So you do everything above plus the following. So for genetic testing, you can consider invasive genetic testing such as amniocentesis at 15 to 20 weeks. And you can also do cell-free fetal DNA if it hasn't been done yet by the time the patient comes to you. So if the patient comes in and there's 16 weeks gestation and they've never had any prenatal care, you can actually do the cell-free fetal DNA at that point. So it only needs done once, but it has to be done. Second trimester screening can only be obtained from the weeks of 15 to 22. And so you want to check some serum markers. There's two methods here. There's the triple screen and the quad screen. So the triple screen checks alpha fetal protein, HCG, and unconjugated estriol. The quad screen will add inhibin A to the triple screen. If the alpha fetal protein is elevated, the next best step is to repeat it. And if it's still elevated, you do an obstetric ultrasound and perform a detailed anatomic survey. If it's still unclear if there's a neural tube defect, you can do amniocentesis with alpha fetal protein and acetylcholinesterase levels. So Alpha-fetoprotein can be elevated with a neural tube defect, and so can acetylcholinesterase. In the second trimester, you also can do your gestational diabetes screen from 24 to 28 weeks. Remember, in your first trimester, if the patient's very high-risk diabetic, you can do an early 1-hour glucose challenge test. But classically on the USMLE, you're going to check for gestational diabetes from 24 to 28 weeks. And so there's a two-step approach. You do a 1-hour glucose challenge test. If abnormal, then you confirm that with a 3-hour glucose tolerance test. So do the 1-hour test, then do the 3-hour test, and you do that from weeks 24 to 28. That's tested a lot. The Tdap can be given at any point greater than 27 weeks gestation, and it has to be given once during every pregnancy. In the second trimester, you repeat the RPR, the CBC, and your type-in screen, and you give RhoGAM if they're Rh negative, and you want to give that at weeks 28 to 32 weeks. Very commonly tested as well. You also give RhoGAM at less than 72 hours after delivery if the infant is Rhd positive. All right, so most high-yield things so far. We talked about the genetic testing. You have cell-free fetal DNA. It's done after 10 weeks, at least one time during pregnancy. Chorionic villus sampling is at 10 to 13 weeks. Amniocentesis is at 15 to 20 weeks. You can do first trimester screening with beta-HCG, PA-PPA, as well as nuchal translucency at 9 to 13 weeks. Generally, you check for gestational diabetes with the 1-hour and 3-hour test at 24 to 28 weeks. If the patient has elevated AFP levels on their second trimester screening, then you would do an obstetric ultrasound to look for neural tube defects. Remember, neural tube defects will have elevated alpha-fetoprotein and acetylcholinesterase levels. And last but not least here, Tdap is given at any point after 27 weeks, and RhoGAM is given at 28 to 32 weeks if the patient is Rh negative. And you also give RhoGAM at less than 72 hours after delivery if the infant is Rhd positive. All that is very highly tested. For the third trimester from 28 and up weeks, you would do genetic testing, so cell-free fetal DNA if it hasn't been done yet. Remember, it only needs to be done once. And you also do group B strep screening, obtaining that at 36 to 38 weeks gestation. If the mom has a fever during delivery or the gestational age is less than 35 weeks with signs of infection at delivery, your next best step is to get neonatal blood cultures as well. Group B strep positive mothers get ampicillin, cefazolin, or penicillin, and must be greater than 4 hours prior to delivery to be considered adequately treated. It takes time to get to appropriate serum levels of the medication. Ampicillin is given in all mothers delivering at less than 37 weeks with an unknown Group B strep status, or if the membranes are ruptured for over 18 hours in a patient with unknown Group B strep status. There's no point in getting a Group B strep culture during labor because it takes 24 to 48 hours to incubate. So that's usually not the right answer. But make sure that you know that if you don't know the Group B strep status of the mom and they deliver at less than 37 weeks, you give ampicillin, or if their membranes are ruptured for over 18 hours. I've seen both of those tested. And in the third trimester, you can repeat the HIV test. Remember, HIV-positive mothers in resource-rich areas should not breastfeed because HIV and Hep B can be passed on to infants in the breast milk. Now let's do kind of like a quick crash course review of screening tests. So first trimester screening, you're going to do the beta-HCG, nuchal translucency, and the PA-PP test, and that's going to be at 9 to 13 weeks. A low PAP plus high beta-HCG can indicate trisomy 21, and a low PAP with a low beta-HCG can indicate trisomy 13 or 18. You do cell-free fetal DNA after 10 weeks gestation, and it has to be done at least once during pregnancy. And chorionic villus sampling can be done at weeks 10 to 13, but there's a risk of spontaneous abortion, so many parents will actually decide not to get that. For second trimester quadruple screening, you check the alpha-fetoprotein, estriol, inhibin A, and beta-HCG at 15 to 22 weeks. For trisomy 13, all screening will be normal. For trisomy 18, all those levels will be low. And for trisomy 21, you'll have an elevated beta-HCG and inhibin A. So I remember the mnemonic HI for HCG and I for inhibin A. So if you have trisomy 21, you say hi. That's just how I remember it. Amniocentesis, you check at 15 to 20 weeks, but there is a risk of rupture of membranes and pregnancy loss with amniocentesis. And you do your second trimester ultrasound at ages 18 to 20 weeks gestation. These are all really high-yield timeframes for screening tests to know. All right, let's do a prenatal vaccine high-yield crash course. I know that this is a lot, so bear with me. Pay more attention to the stuff that is bolded. So for all pregnancies, you would do the inactivated influenza vaccine given in any trimester. Does not matter. The Tdap is given in the 3rd trimester after 27 weeks to confer immunity to the baby. And then Rho-D immunoglobulin is given if the patient is Rh negative at weeks 28 to 32. Make sure you memorize that. And you also give RhoGAM at less than 72 hours after delivery if the infant is Rhd positive to prevent maternal sensitization. The following vaccines are contraindicated in pregnancy: HPV, MMR, varicella, and live influenza. Remember, you just give the inactivated influenza. And you only give in high-risk patients the Hep A and Hep B vaccine, pneumonia and meningococcus vaccine, H flu, and VZIG.